So just some housekeeping. To remind, although I think everyone on this call is here because they know that patient-centered outcomes research helps people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard in assessing the value of healthcare options. I love this list. Given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options? And what are the potential benefits and harms of those options? What can I do to improve the outcomes that are most important to me? How can clinicians and the care delivery systems they work in help me make the best decisions about my health and health care? Next slide, Michael, thank you. So I hope that many of you either were with us on April 3rd or have had a chance to see the video sessions. This now represents the second tranche of what we're doing with our PCOR grant. Specifically, we won't make you sit still for 3 hours this time. Rather, we're just going to do an hour or however long you want to chat on an overview of integrating qualitative interviews and quantitative surveys in PCOR. Our next 2 sessions will be on Thursday afternoons and talk about best practices for quantitative surveys in PCOR and best practices for qualitative interviews in PCOR. Next slide. So today, in our first one, we talked about what makes PCOR different, engaging patients, measuring what matters, and I talked about the OI Foundation Patient Registry, which we hope all of you will eventually want to use. Next slide. Today, we are going to have a perspective chat by Michelle Dupre, is the chair of our education committee for the PCOR grant. Then I'll talk about some recent perspectives on PCOR by the foundation, and Bryce and Amy will come back with the talks we've just discussed, and then we'll have time for an open mic and discussion, and we're eager to make this as interactive as possible. Next slide, please. So next is not me, but we're going to switch to Michelle. And it gives me huge pleasure to introduce Michelle Dupre, who has been just spectacular in helping us move our education program, both for these sessions and also for the regional meetings that Tracy Hart has been supporting across the country. So Michelle, welcome, and thank you for supporting us.
Thank you, Dr. Tosi, and thank you for all the effort you put in to this project and so many others. I just wanted to say to the group and to the OI community as a whole why PCOR is so important. Just because we've operated in a healthcare system that hasn't necessarily been patient-centered doesn't mean that we've gotten bad healthcare. It's just a different way of looking at things in perspective. When I became an adult 35 years ago, my concerns were not being addressed by any research projects out there. And it's only been in the past 5 years that research has really turned to focus on things I care about, things that I'm interested in, and other OI adults similar to myself are interested in. So it's a new way of looking at, and it's a partnership in how research is prioritized and moving forward. And I hope everybody gets excited about this as much as I've gotten excited about it, because I think it's going to really make a huge difference to the OI community. So I thank you all for participating.
Thank you tremendously. I apologize. We wanted to show your image, and thanks to my computer glitch, that didn't happen. But thank you tremendously. So why are we here today? And who's on the call? And what do I mean by that? Next slide. So I would argue that this work is about change. I know many of the people on the call and welcome people who I haven't met. As a pediatric orthopedic surgeon who's been in practice longer than I want to admit, now over 35 years, I have been stunned by the wonderful changes that have happened in OI care. As an orthopedic surgeon, the use of bisphosphonates, femoral rotting, and more recently, the recognition of watching out for pulmonary complications have extraordinarily improved the quality of what I'm able to deliver. But the question is, how do we tell people, how do we help inform people about best practices and what to watch out for? And how do we help explain how these changes are going to impact adulthood? So a number of projects have been going on. I published the Adult Natural History Study a few years ago. We have the ongoing BBDC longitudinal study. We'll talk many times about our contact registry. And the Jamie Kendall Research Fund have all been working to try to document that change, measure that change, improve the quality of the information available. Next slide. So, can we develop a strategy that will help capture this rapidly changing story, not just for today, but for the long term? And who are the people most interested in helping out? Next slide. To try to raise some funds that would help us move this forward, I'm Tracy Hart, our speaker Bryce Reeve, and myself submitted a PCOR grant now a year and a half ago for one of their patient engagement awards to expand the community's interest and ability to participate in research. And we were tickled pink to win it, and we launched it a year ago, and we have another year to run. Next slide. In that grant, we wrote about what we wanted to do, and everyone on this call, I hope, will be part of it. First, we wanted to increase the capacity of OI patients, caregivers, clinicians, and researchers to participate in PCOR activities. And specifically, as we expand the community, to be sure everyone was speaking the same language and were committed to the concept of patient-centered outcome research. And a key component of that is to try to ensure that everyone participating pays specific attention to the research topics that the OI community itself regards as a high priority. As another part of this that I've alluded to is the incredible work Tracy has been doing in terms of trying to increase outreach to both clinical centers and to the community itself. Next slide. So this is an inside out, backwards, and perhaps upside down welcome. While we've known and worked with many of you individually over the years, we haven't really focused on these efforts as a team, and we are eager to include all OI centers in OIF activities. What's fun is who's on the list? Well, the folks on this call represent a broad range of professions and previous training. And some of you work at sites where we have had minimal interaction, so we're particularly excited to get to know you. And more important, many of you have reached out and pointed out that you are already engaged in various forms of PCOR and PRO activities. And so one of our particularly important questions is, how can we collaborate? How can we leverage what's going on? Next slide.
Dr. Tosi, you ended up muted somehow. Not quite sure what happened.
Thank you. So, can we leverage the energy and enthusiasm that we have so far to create an OI PCOR community, enhance collaboration that supports research, care, and efforts, help people with OI and their caregivers really have the language to communicate and make the best possible informed healthcare decisions. So, as part of that, I now welcome and turn over the mic to my good colleague, Bryce Reeve. Next slide.
Yes. Thank you, Dr. Tosi. Very
I
good.
left out a slide, Bryce, I apologize. So, this is our responsibility to the grant. Sorry, Bryce. I think most of you have gotten the email. We will be looking forward to trying to establish a time to really start working on a partnership. Apologize for that. Now, Bryce Reeve.
Very good. Thank you very much, Dr. Tosi. I'm going to leave my video off. Let's see, as a way to preserve the bandwidth on my internet, but hopefully you can still see the picture of me, and you can imagine my lips moving while I'm talking. Let's see, I just want to confirm, Michael or Rachel, can you see my PowerPoint slide?
Looks good.
Great. Okay. So I'm going to take the first shot, and then my good friend and colleague, Dr. Amy Corneli, will talk about more qualitative methods there. But my focus for this particular short talk will be focused on using surveys and questionnaires to help us capture patient experiences and perspectives. I do want to note my email. If you have any questions or comments or want to follow up with me, my email's at the bottom of the slide. It's my first name, bryce.reeve@duke.edu. So here we go. So the first thing, I just want to make a quick note. We're all familiar from our last session about thinking about measuring what matters under patient-centered outcomes research, and we describe patient-centered outcomes as outcomes that are most important to patients and other key stakeholders. And what I want to make sure is very clear is that patient-centered outcomes are not always patient-powered outcomes, and in reverse, not all patient-powered outcomes are patient-centered outcomes in patient-centered outcomes research. So let's take the OI as an example. So what are some of the most important outcomes for the OI community? Now, I'm not a clinician, so if I make something wrong, please forgive me, but this is just an example. But from what I've been reading is, I imagine, of course, for many, fractures and bone density are key, potentially patient-centered outcomes, and the goal is to help reduce the number of fractures. There are other types of course, patient-centered outcomes when we talk to patients and patient advocates, and these can be things like the patient's symptoms, quality of life, and their functioning. We might also be interested in terms of patient-centered outcomes of looking at the caregiver, like parents with children with OI and their impact for caring for their particular child with OI. We might also be interested in outcomes of needs and preferences, and this could be the needs and preferences for both the patient or the caregiver themselves. So there are lots of different certain outcomes, but where we get the source of this information might vary. And so you would imagine that our goal in many ways is to capture the patient voice. And in particular, they can certainly are the experts and gold standard for talking about what symptoms they're experiencing, what their quality of life is, and functioning. We may also reach out to caregivers of individuals with OI to get their perspectives. Again, could it be symptoms, functioning, quality of life, or caregiver impact? Other sources of data on patient-centered outcomes might come from clinicians. They may come from x-rays, or for things like functioning, we might actually have these performance-based measures like grip strength to help us understand their functioning. So there's a range of outcomes that are important in patient-centered outcomes research, as well as there's a range of sources where we collect this type of data. The U.S. Food and Drug Administration does categorize two broad themes of outcome measures. One of them being biomarkers like radiographic x-rays and things like that. They might also collect things like saliva or blood and other things like that. And we will not be focusing on biomarkers for this talk today, but more focusing on what is deemed clinical outcome assessments. And as we learned from our last training session, there are a range of different types of clinical outcome assessments, and it varies based on the source. There are patient-reported outcome measures we call PROs, clinician-reported measures. Observer-reported measures are ones where the caregiver would provide some perspective on the person's symptoms, functioning, or needs. Performance outcome measures are ones where we ask the individual to do a task, whether it's physical or cognitive, and a trainer evaluates their ability to perform that task. Or a new wave of interest in outcome assessments is using digital measures like activity trackers and monitors and things like that. For the purpose of today's conversation, I am just going to focus on patient-reported outcome measures, clinician-reported measures, and observer-reported measures, because these are the ones where typically the best measure is one that's either a survey or questionnaire. And so with that, I will, in my brief amount of time, go through 8 key questions about thinking about integrating surveys and questionnaires in patient-centered outcomes research. And this includes what outcomes do we want to measure? How will the measure be used? Who is the source for this information? What kind of measure do I need? Where do I find the measure? What are the qualities of a good measure? When should I have participants complete the measure? And then lastly, what mode of data collection should I use? For the first question, what outcomes do I want to measure? And I did summarize this a little bit on our talk a few weeks ago under measuring what matters, but I want to repeat it again here in case you're new to the series. And so you can imagine we have a range of patient-centered outcomes, and the key is, how do we choose particular outcomes? Well, there's a number of ways that helps inform what outcomes we want to include in patient-centered outcomes research. Most of the outcomes selected come from this actual research study objectives, aims, or research questions. These the study objective could be, what's the impact of treatment X on persons like physical functioning? Now, what ultimately informs what should be the study objectives and research questions, as well as what outcomes and measures, should be informed by a multidisciplinary stakeholder group. And that stakeholder group should include patient and patient advocates, but might also include research investigators, outcomes researchers like myself, and many others. In addition, the type of outcomes you include in your study will obviously be informed by the intervention and the type of intervention you're going to use. As well as you might inform your outcomes based on previous research using the same intervention or different intervention in the OI community. The second question is, how will the measure be used? And the FDA calls this sort of the context of use of a particular research tool or survey. Surveys and questionnaires can be used in a broad range of patient-centered outcomes research from the macro to the micro level. At the macro level is using surveys or questionnaires for population surveillance and to help look at prevalence, incidence, and trend rates over time. We use surveys and questionnaires of patient-centered outcomes research, of course, for research to look at either the efficacy or effectiveness as an endpoint. which, the outcome could be either a primary, secondary outcome, or the questionnaire could be used as an exploratory endpoint. We might use the questionnaire to assess tolerability to a particular drug or adverse events associated with a particular treatment. And an interesting area of work is using the survey questionnaire for health preference assessment. Now, health preference assessment is something unique and interesting because typically what we're familiar with is we might use surveys and questionnaires to measure like symptoms and functional status. So we might get like a pain measure. We might get a depression measure. We might get a physical functioning measure. However, what health preference assessment allows us to do is to look at the trade-offs between the efficacy of a particular treatment balanced with the adverse events or tolerability of the treatment. And so under health preference assessment, we can actually work with patients to provide what we call values for certain particular outcomes to determine which is the best treatment that has the most effective outcome with the reduced number of adverse events or tolerability. And then at the micro level, we also use these surveys or questionnaires for clinical practice purposes, what we call sort of the real world setting. And we can use questions and surveys to help us screen for symptoms, for example, or adverse events. We can actually use surveys to monitor a patient's physical functioning or symptoms or mental health status over time. We might also use questionnaires and surveys to do risk prediction. Based on a patient's answers to particular questions, is that person at risk for future worsened morbidity? So for all these reasons, we might use a survey or questionnaire in patient-centered outcomes research to address very different needs. And depending on whether we're using this for population surveillance, research, or clinical practice, the type of questionnaire can actually vary. So again, it's important to understand how the surveys can be used for what particular context of use. The third issue to consider is who is the source of the information. As an example, I've already talked about all the different sources, but let's use one particular outcome, and I'll talk to you about how we can use multiple sources of information. So for example, imagine we're thinking about measuring individuals' physical functioning level. Well, who do we ask to provide this information? Well, for many of us who are patient-centric, the patient is typically the gold standard for providing what he or she is particularly feeling he or she's functional level is. But for reasons, we might ask the observer, like a parent, to report on their child's functioning, and that would be an observer-reported measure. Sometimes clinicians are reporting on the person's functioning. They can look at how the person moves within the clinic, the lab there, and then provide an assessment of the functioning. As I mentioned before, we might have the patient do some performance metrics like a grip strength exercise or get up and go, or like a distance test. And as I said, you're starting to use more use of these digital measures to look at activity levels, movement, and other things like that. So for one single outcome, physical functioning, there are 5 different ways we can assess physical functioning. Now, in total, what some key points to note here is these particular ways, one measure is not a duplicative of the other measure. And what we typically find in our field is these are not 100% entirely correlated together. What we find in terms of correlation is that they're moderately correlated because each particular source or method to assess functioning is capturing some different aspect or has some particular experience or perspective. So one measure is not necessarily wrong, it just provides a different perspective. So for example, for things like digital measures or performance outcome measures, they can measure very specific movements, whether it's like arm movement, leg movement, or some type of activity like distances or things like that. When we ask patients to report on their functioning, not only can they report on their movement and mobility, but oftentimes they reflect on how their functioning impacts their daily living. So we get a much more broader assessment from the patient perspectives. We can also, again, as I said, reach out to other people like caregivers, clinicians. From multiple research settings, we do know that caregivers and clinicians don't, again, necessarily correlate highly with the patient perspectives. I do work in a number of different settings. Most recently, I've done some work in cancer. What we find compared to the patient is that caregivers tend to underreport physical functioning, and clinicians overreport physical functioning compared to the patients themselves. So again, you need to take in consideration which source of information you want to use, and sometimes it might be interesting to get multiple sources on the same particular outcome. What kind of measure do I need? With surveys or questionnaires, there are multiple types of measures that you can use. So the type of questions can either be what we call close-ended, and here's an example, rate your current health, poor, fair, good, very good, or excellent. That's called a closed-ended question. And we also have open-ended questions and questionnaires. Now, typically we shy away from open-ended questionnaires simply because, especially if you're collecting this over perhaps hundreds or thousands of people, it makes it challenging for the data analyst to summarize the data in a way that can be used for analysis. So typically we use closed-ended surveys. There are also a difference among measures between what we call generic versus disease-specific measures. So let me differentiate generic versus disease-specific. So generic surveys are surveys or measures, for example, for measuring like fatigue, that can be used across multiple conditions or diseases. And so an example we talked about on the last session are the NIH's Patient-Reported Outcome Measurement Information System, or PROMIS. That is a generic tool, and that patient-reported outcome measure was designed to be used across different populations like OI, but also could be used in cancer or heart disease or COPD or many other conditions as well. And the value of generic measures is they allow you to compare the relative burden of symptoms and functioning in one population versus the other. The downside of generic measures is that they don't have information or questions that are specific to a unique population. And that's why there's some interest to disease-specific or condition-specific measures where we can make sure that, is like for the OI community, that we have questions that are specifically targeted to make sure we capture the range of experiences for which individual OI have. There's also differences among measures between what we call single or descriptive items versus multi-item scales. This requires a much longer discussion, probably that involves some psychometric theory, but simply a single question by itself can be good for descriptive purposes, for describing what % of people answered none, mild, moderate, or severe pain. However, if you're using a measure in a clinical trial or for patient-centered outcomes research and really want to have a highly valid and reliable measure, oftentimes multiple fatigue questions that sum up to a single fatigue score are more ideal because they give you better precision and a better ability to estimate changes over time. We also have a difference between what we call psychometric or profile measures versus preference-based measures. And with psychometric profile measures, those are simply measures like PROMIS that gives you individual scores for multiple symptoms or function, whatever you happen to be interested in. So, for example, profile measures can give you a pain score, a depression score, an anxiety score, physical functioning score, etc. However, a preference-based measure, which is used for doing efficacy risk trade-off estimates or for health economic analysis models, they typically aggregate across multiple domains and only have a single score that represents all of a person's health state or all of the patient's preferences. So again, depending on their goal of the study might inform whether you're using a profile measure, which most of us are familiar with, or a preference-based measure. Where do I find these particular measures? Well, ideally, what you're looking for is an existing measure or survey that has hopefully been validated in the OI population. When you find those measures, you feel really comfortable moving forward with your research project and collecting data on it. However, sometimes, unfortunately, you just can't find the right measure or the right measure that's been validated in the OI population. So, for example, as the first sub-bullet, you might find an existing measure of, again, fatigue, but it has not been validated in OI population. Well, can you use it? Well, you probably could, but you probably need some small steps, some of the qualitative methods you hear about from Amy, to make sure that it is a valid measure and appropriate for use in the OI population. As a second sub-bullet indicates, you might find an existing measure again of fatigue, but might not have some items that are appropriate for the OI population. So it might need to be adapted, add items, maybe drop some items. And again, if you do this, you would need to do some additional validation steps at what I call the moderate level. Or you might find, unfortunately, that for a particular outcome of interest, you have no good measure out there. And so you might have to design that measure. And of course, anytime you want to design a new measure, that will require significant a number of steps, both qualitative and quantitative, to help develop and validate that particular measure. Now, where can you find these measures? Actually, the point here is that anytime you need to either do some slight modification or validation, I do recommend reaching out to survey methodologists to guide you for that particular step. Now, to find these measures, of course, if everyone's familiar with the Google searches and looking through different databases, I like to find previous studies, for example, in the OI community, and see what measures they used. But please note, sometimes just because a study used it doesn't mean it's always the best measure for your particular study. Another thing I also recommend is phone a friend or call a friend or colleague and reach out and says, hey, now, do you know of any good physical functioning measure that you would recommend for my population as well? What are the qualities of a good measure? Well, there are a lot of things you're looking at, but overall, the key things is you want to look at is the measure valid? Does it measure what it's supposed to measure? So what does this measure what does this survey measure is what we're looking at in terms of validity. The other issue is reliability, how precise you want your measure. And again, there are different types of reliability I won't go into today, but again, that's something because you want to make sure not only what you're measuring in terms of validity, but how well you're measuring, and that's reliability. The third thing to keep in mind is respondent burden. And here we need to make sure we avoid throwing everything into a survey and measuring every single outcome under the sun. We need to be respectful of individuals' time and make sure that the questionnaire is only optimized to measure the key outcomes of interest in your particular study. And we don't want to overwhelm our particular individuals. When should I have participants complete the measure? There are a number of different guidelines. Most importantly, you need to make sure is in terms of when you collect data from your individuals in your outcomes research study, is to make sure that you measure at a time that's consistent with your research questions and endpoint construction. So if your research question is looking at the impact of potentially surgery on improving functioning, that means you'll need to have a pre-surgery and post-surgery survey to look at changes over time. In addition, of course, we always recommend at the beginning of the study have a baseline measure, because if you're interested in such things as fatigue, those are certain outcomes that everyone has. It's important to know where people are starting from even before you start your intervention. Also, you need to collect data at points when you expect changes in the patient's health and functioning. Oftentimes, for studies, you're collecting data both prior to and subsequent to an intervention. And importantly, in patient-centered outcomes research, often what's not done in clinical trials, because trials are only done for a short term, is we also need to understand how these interventions impact patients long-term. So that's also recommended as well. I do want to make a note that we need to be cautious about not over-surveying patients. Sometimes people want to collect continuous data, like weekly data. And if you have a year-long study and asking patients to complete this on a weekly basis, that can be quite overwhelming. So we can get survey fatigue. And when survey fatigue kicks in, individuals either stop completing this, stop even pulling up the survey, or might stop the survey midway. So we need to be conscious about that. And my last question is, what mode of data collection? So if you're an old timer like me, paper and pencil, I love taking surveys on paper still, because I just love the feeling of holding a pen and looking at the questions on the paper. However, for the, we have to recognize that most surveys are now done electronically and can be completed on the computer, laptop, or an individual's smartphone. Oftentimes, surveys can be done through an interviewer-administered questionnaire, either in person or over the phone. The strength of doing an interviewer-administered survey is especially for populations or individuals where there would be low literacy rates and they can't read. So if you and they would be excluded if you required them to complete it on their own. So an interviewer-administered survey can help overcome low literacy rates. For those that don't like talking to a real person, we actually can do interactive voice response systems. For example, like when you call the bank and you talk to or make a reservation online through an airline, you hear a computer automated voice system, which removes an individual from being involved in the actual survey. One question I get all the time for patient-centered outcomes research is, hey, can I mix the different modes in the same study? And it makes sense because obviously you want to tailor the mode to the patient's individual preferences. Some people like paper, some people like computers, some people would rather talk to someone over the phone. Now for advice, typically we recommend if you can stick to one mode, you'll be better off. But again, we recognize that there are times when you need multiple modes, like electronic survey and a interviewer-administered survey. Now, what we have done in our field is we've actually compared responses across these different modes. In general, we sort of get negligible differences. In other words, you get the same answers, whether it's electronic or paper. The only time it starts to make a difference is when you introduce a person like an interviewer, and in particular, if they're talking about very sensitive subjects. Under those conditions, sometimes you get the patient might answer differently than they would independently on their own. One area that I've seen in my own work in cancer is sexual functioning, and we've seen that patients tend to answer questions a little bit differently when they're answering questions on their sexual activity and functioning, independent versus having someone ask the question over the phone. So those are the 8 key things to think about. And just to summarize, surveys and questionnaires are a great tool to capture patient experiences. You can collect a lot of data by distributing your survey broadly and be able to analyze that particular data. As I note, you need to be extremely mindful of survey fatigue. So you need to consider when and how often, and are you only collecting it to help assess your particular research questions. There is a tendency to over-collect data just for, you think, hey, I might have additional future studies, but again, try to resist that because each time you're asking a survey, you're asking someone to contribute their time and need to be respectful for that. There are really good measures out there, patient-reported measures, clinician-reported measures, observer-reported measures, and performance measures out there. So we should, I try to avoid always thinking you always need to create a new measure, but there might be lacking of good OI-specific measures out there, and maybe that's an area that hopefully the OI Foundation and Dr. Toes and others can work on together. If you are interested in this area, I'm going to go much more in depth on some of these topics, as well as introduce new topics on Thursday, July 16th. And you can join me at that time, and we'll go ahead and have a whole hour devoted to these best practices for integrating surveys. The last point I'm going to end on is that while I really love surveys and questionnaires, they only give you a specific one specific perspective on what's going on in individual lives and does not give you the depth of information you can learn through qualitative methods and approaches. The analogy I like to learn is if you're doing a drawing, the quantitative surveys is sort of like doing a pencil drawing, connecting point to point to point. But to get the real color, the vibrance of what's going on in that picture or in individuals' lives is when we turn over to qualitative methods. And with that, I'm going to turn it over to my good friend and colleague, Dr. Amy Corneli, who's going to lead us through that discussion.
Great. Thanks very much, Bryce. I'm going to start my video. I don't have a pretty picture like Bryce does on his screen. And let me share my screen. Can everybody hear me?
Yes.
Great. All right. And now can you see my slides?
Yes.
I'm trying to, there we go. I think I have them now in presentation mode. Well, hello everyone. It's nice to be back with you again. And as Bryce mentioned, I'm going to focus on qualitative methods to capture that patient's experience, to get really at that color that Bryce just spoke about. And there's 4 topics that I'll talk about today. First, we'll define really what qualitative research is. Then we'll talk about the common uses of qualitative research and when and methods and when it should be used and when not. We'll focus a little bit on how to select participants for qualitative research, and then also talk about the differences and when to use in-depth interviews and focus group discussions, as those are the 2 most common methods used in qualitative research. So we'll start with the definition of qualitative research. Qualitative research seeks to understand a given research problem or topic from the perspectives of the local population it involves. Qualitative research is especially effective at obtaining culturally specific information about the values, opinions, behaviors, and social context of particular populations. So you've probably heard there's lots of different types of qualitative research. There's phenomenology, grounded theory, ethnography, and they all have certain purposes. What I think the best type of qualitative research that works well with the core type research is something that's called qualitative description. And this slide describes really what that is. And it provides us an opportunity to describe a comprehensive summary of events in everyday terms. It allows us to investigate and describe the who, what, when, and where of specific events. And it really is the method that we want to use when we want a straight description of what's happening and what we're investigating. You know, we don't want to go in and present findings in a very abstract, highly abstract way, but we want to stay close to the participant voice. We want to use words, we want to use categories that basically represent what they told us in the interviews and the focus group. So we stay very close to their perspective and those words. And that's what qualitative description does. So there's lots of different uses of qualitative research. They're all listed here. Clearly, the main one is to explore and understand phenomena, so understand some sort of event. And in PCOR, it's to understand participants' experiences and then what they want. Often, qualitative research is used to develop interventions. So you go talk to patients, you go talk to populations and find out, well, what do they want to be intervened on? And then you talk about, well, how to develop that intervention. Or you come up with an intervention and you go to the patient population and find out what they think about it. What can be done to make it better? So you start off with an intervention that is as good as possible. Research or qualitative research can be done to inform clinical care and research. We do a lot of studies with clinicians that they just want to find out more about what patients think. How can we do a better job at what we're doing as a clinician? And then we go talk to patients about that. Clearly, as Bryce has talked about, qualitative research can inform survey development. It can also be used to explain clinical research findings. So say you've done a clinical trial and you get some findings that weren't expected or you don't fully understand, and you can go to the patient population and talk to them about it using qualitative methods. And then lastly, they also use to explain quantitative survey findings. So you have these findings from the surveys and you want to find out more about the context around them. So you can go back to the participants who completed the survey, or you go to other people in that population and say, this is what we found. What do you think about it? Okay, this slide focuses on when to use qualitative research. There's real specific ways in it where it's useful and where it's not. And so if you want to find out that richness, that color about participants' perceptions, practices, beliefs, and experiences about a certain topic or an event, qualitative research is what you want to do. And so a typical question could be, what concerns do adolescents with OI have about their medical care as they transition into adulthood? Very open-ended. Qualitative methods is not appropriate when you want to quantify relationships. Is this associated with this? Or you want to quantify the variation. So how many people are interested in this? So a question that would not be appropriate for qualitative is how many adolescents with OI are concerned about their medical care as they transition into adulthood? That would be a question for a survey where you can ask to more people. When you want to get that broad information, you use that qualitative research methods. And then just one other slide, just to compare and contrast with some of the information that Bryce suggested. In quantitative research, so in surveys, and Bryce mentioned this, that you primarily use these close-ended questions, and you have these very highly structured surveys. So you ask the questions the same way to every participant in the same order in every participant. There's no flexibility. The response options are chosen, so participants can only choose from those 5 response options or whatever they may be. And in qualitative, it's absolutely the opposite. We typically use open-ended. We can ask some close-ended, but they're always followed up with an open-ended because we want people to talk and talk and talk. And we have to be flexible in what we want to do because we want participants to lead the discussions. We want them to be in charge of what they want to tell us that's important. And to be able to do that well, we have to be flexible. There are 2 main type of data collection tools that we use in qualitative research: in-depth interviews and focus group discussions. And we'll talk a little bit about each of those and when to decide to do each one. So in-depth interviews are great to use when you really want to know as much as you can about an individual's circumstances, an individual's perceptions, beliefs, practices, experiences about a certain topic or an event. In-depth interviews are perfect for that. They're great for exploring a priority topic, so topics that you know you want to talk about, but also they're great because unrelated topics are going to come up and you can follow through with those and ask more questions about them as long as it's within your overall domain that's been approved by your IRB. In-depth interviews are perfect and really the only way to go between the qualitative methods for exploring sensitive topics. So a lot of times, a lot of us, we don't really like talking about sensitive topics or topics that are private to us, but maybe we would to one other person. But we wouldn't want to do that in a group. So interviews are really good for sensitive topics. And the outcome are this in-depth, it's rich information, the color about individual perceptions, practices, beliefs, and experiences about a specific topic or an event. Now, there are different types of in-depth interviews. There are unstructured, and these aren't done that often in qualitative description. They can be, but usually you go into an interview and you have 2 questions, 2 grand tour questions that you're going to ask. You start off this interview with that one first question, and then you just come up with questions on the spot based on what the participant is telling you. And so you have to really listen well and really know your topic well to be able to keep that conversation going with 2 questions, say, for like an hour. On the other side of the spectrum, you have structured questionnaires, which we also don't use that often. And that's when you have your predefined questions and you really don't have any flexibility. And as you can tell, we don't really like to do that so much in in-depth interviews, but they do exist. What most people do is this in-between approach, which is these semi-structured interviews. And so you'll have a questionnaire, maybe with 10 or 20 questions that are all predefined, they're on there, but you have that flexibility to modify those questions if you've already talked about it before. You can explore new topics. So say you ask the question, but they say something else and you want them to talk more. So you ask all these new questions to get them to talk more. You have the flexibility to change the order. So say you're talking about question number 1 and they mention something that you know is going to come back up in question number 15. Well, you can start that discussion now because it's important to the participant to talk about it now, have them keep going, and then you just jump back into your guide and the other questions when it's appropriate. So moving on to focus group discussions. So these are small group discussions with about 6 to 8 people. That usually makes it manageable. And usually, not always, but usually people are similar in terms of whatever experience that you're interested in learning more about. The main thing with focus group discussions is you're trying to get at community norms. You're trying to find out what a group of participants think. And the reason you get these people together is because they have these great interactions between participants to generate more interesting data. And the output is this broad overview of topics. So the in-depth interview, you get that in-depth, rich patient experiences versus focus groups, you really get this broader overview of what might be going on or how the broader community or social norms may be influencing those individual perspectives. So I added this slide because focus groups are used, unfortunately, incorrectly a lot. And so they're appropriate if you want to learn more about community, family, group norms, so these broader issues, things that people are going to be comfortable talking about with all these other people and people they probably don't know. Focus groups are not appropriate when you want to learn about personal beliefs, attitude, practices, or experiences. They're not good to use when the topic is really highly charged or controversial, if the topic is sensitive or highly personal, or if you need quantifiable results. And the last bullet, focus groups aren't good for those quantifiable results because not everybody will share a topic on each of the questions that are asked. Just think about the conversations you have when you go around the room. You're not asking, when you're having a conversation with somebody, not everybody is offering an option for or contributing to the conversation. Same with a focus group. Not everybody talks all the time, and you're certainly not going around the group and asking each person to answer each question. If the topic is sensitive, it's not great to ask that because people may not want to talk about it with other people in there, or they may add some stuff that's socially desirable. It's what they think you want to hear or what they think is socially acceptable, and they offer it even though it's really not what they think. So we leave those to in-depth interviews. And one last slide about focus groups, and this is bringing in an ethics angle, and it goes again with that some people don't want to share information or share their views in a group setting. And so when we do focus groups during recruitment and consenting, we let participants know during in the informed consent form that they are being asked to participate in a group discussion. And we tell them what the topics are, who's going to be in the group, are they like them, are they different from them, and so then participants can make that informed decisions whether or not they want to participate in that group activity. So sampling in qualitative research can be tricky. So what we normally do is called purposefully propositive sampling, and it's basically you are choosing participants on purpose because they have the experience, they have the information you want to know about. So lots of times in other type of research, you get a random sample. And we can do random samples in qualitative research in some situations, but normally we want to find people that have that experience. If you take a random sample, say of everybody in your town, they may have not had a specific experience. They may not have done what you're interested in. And if they're part of your sample, you ask them questions, they can't answer them, they don't have that experience, then those data will not be rich or useful whatsoever. So you really want to find people who have that experience, and then you interview them, and that's how you get that really rich, detailed information. Trying to determine the number of interviews is always tricky. One guidepost that we follow, there has been research that's been done that says around 12 interviews, you usually start to hear the same information over and over, and that's with a group of people who are very similar and with a very narrow objective, but that's what we normally use as a guidepost, is 12 interviews. And then research by the same group have also looked at the number of focus groups that you start to hear the same information over and over again. And that's usually around 3, can be up to 6 focus groups. And again, there's a lot of caveats, depends on how structured your guide is, how similar or different the focus group participants are. So usually we kind of do around 4 focus groups per population. So to wrap it up, qualitative methods are very appropriate for learning that rich descriptive information about people's lives and experiences. It can be used to inform clinical care and research and survey design, to explain research findings. If qualitative research is something that's of interest to you and you don't have expertise in it, try to find those social scientists and other experts who can help you get started and collaborate with them. That's something that we do as a methodologist in our department. I help other people. I don't know the content, they know the content. I have the methods, we bring it together, and we have these really great partnerships. And we're going to have another seminar with a colleague of mine, Terry Sweezy, who will provide an hour session on the best practices for qualitative interviews, and she'll go into more in-depth information about how to really do these interviews, how to be able to get that in-depth information that I've talked so much about. So I think you'll enjoy this. Terry's been doing this for a really long time, and it's the best out there for doing in-depth interviews. So you'll enjoy that. And then I just have some slides here for when these get posted of the different resources to learn a little bit more. So thank you.
Amy and Bryce, terrific job. Thank you so very, very much. For all my good intentions, we've run 2 minutes over, but we are very eager to engage you all in any questions you might have. And so we really would welcome you all to unmute. And we welcome your thoughts. It's always a little bit embarrassing to be first to speak. Just a couple more housekeeping points before we move on to that. We will ask you to just do a very quick survey for us today. However, for those of you who haven't filled out the original survey asking for your interests, your experience, how to reach you best, etc., we would really appreciate it if you would answer the additional questions as we try to, again, look towards a robust effort going forward.
Amy, this is Tracy Hart. I was hoping I could ask you a quick question. When you are working with patient groups like the OIF, is it best to get folks together, a patient group together, before you start developing the questions, or should you develop questions and then share, or what's that engagement like?
That is a great question. And the best way is to start that partnership early on before you develop anything. And that's what at least that's the partnerships that I have, is we get together basically with an investigator or the patient groups that I work with. They have an idea. All right, well, let's sit around the table and talk about that idea. And then we talk about how to research that idea to get at the goals that they want. And then what I normally do is really pick their brains as much as possible so I can learn as much about whatever condition it is or experience and what they really want. And then I'll draft out some questions and then we go back and forth.
Great.
But you really got to get the info at the beginning, and it's just way more enjoyable that way as well.
Yeah, and I think for folks on the call too, we can be that resource for you to connect with various groups of community members as well.
Yep.
And a corollary to that is that our grant is such that our dream is that by next spring, we would have engaged the community enough that we would really have established some research priorities. And you might say, well, aren't there research priorities that are ongoing, particularly through the natural history study? And certainly that is an extraordinary study marching along gallantly. We're so pleased it just got refunded last fall. But the fact of the matter is that this is a disorder that's changing. And I think there are many things that we can start to explore using the OI registry. And that will allow us to reach a much larger population if people choose to be part of the registry. So as part of our grant, we will be looking to try to establish some key priorities for future exploration by next spring, summer.
This is Bryce. So it's a sign here. So while people are thinking of additional questions, one thing I thought I'd point out, and I know Amy has some thoughts as well, is, Amy and I are talking about qualitative and quantitative studies as they're very separate things and very separate research studies. However, we think probably the strongest patient-centered outcomes research studies when you can actually combine both qualitative interviews as well as surveys and questionnaires within the same research study. For example, every time you decide to go out and collect quantitative survey data from, let's say, maybe 100 people, you could potentially randomly sample, some set of 10 to 12 individuals that can give you some more context behind what's going on in terms of the concepts that you're trying to assess in that particular study. Ultimately, what you might hear is called mixed methods is really in an ideal way that you're using both the survey data and the qualitative data together to help inform whatever research question you're trying to address.
Great. Well, we've gone over time. I don't want to put people on the spot, but we certainly welcome your feedback. And please be sure to fill out our little survey so that we can start to know more about what you're doing and what you want to learn about and how you want to participate. So if we don't have anyone who wants to speak up, I will say good evening and thank you so very much for your time and look forward to working with you. Bryce, Amy, Michelle, thank you so much for being part of this, and certainly to Tracy. It's so great to have the OI Foundation supporting these efforts and bringing everyone together. So thanks to you as well. And of course, to your wonderful staff and Michael, who always makes us look good whenever I'm making mistakes. So thank you, everyone. This will be on the web as fast as we can get it there. Thank you.